Hi, this is Dr. Shail from Restore Eye, and for today's case, we have a 60-year-old female who's had white mature cataract since childhood. Also, there is this area of anterior Synechiae, probably due to an untreated corneal ulcer in her childhood. Starting off with a side port and injecting trypan blue dye to stain the anterior capsule. I massage the corneal surface so that the dye spreads uniformly and I get a nice complete stain. I wash off the dye and use viscoelastic to feel the anterior chamber and also achieve some viscodilation. Now, in cases of anterior synechiae, I prefer to cut off the attachment rather than yanking it off. I feel it is considerably less traumatic to the cornea as well as the iris tissue. I go ahead and cut all the fibers and make sure it is free from all attachment to the cornea. My current aim is to achieve a continuous curvilinear capsular axis of approximately 5 to 5.5 mm in diameter. By carefully using the pupil margin as a reliable guide, I am able to create a well-sized, appropriately centered rhexis. A single pass 2.8 mm main incision is made. Now very minimal hydrodissection is done in all quadrants to release all the corticocapsular adhesions. Some more viscoelastic to protect the cornea. The nucleus is rotated and it rotates freely, suggesting a successful hydrodissection. Now for the nucleus management, I start with a trench down the middle. Now while trenching, I punch out a hole in the nucleus. This is a danger sign as I might have punctured the posterior capsule. I have to stay vigilant during the subsequent steps of nuclear emulsification and notice if I have caused a posterior capsular rent. This is the tricky part about a long-standing white cataract, as some part of the nucleus might be fibrotic and dense and some part might be soft and mushy. A good control on the foot pedal is a must. So the nucleus is divided into smaller pieces and emulsified one by one. It is a small pupil, but staying inside the central 3 mm safe zone is a very safe procedure. One half of the nucleus is emulsified and now I am emulsifying the other half. The last piece is quite dense and you can also see the yellowish dense part. I refill the eye with viscoelastic, position the pieces away from the cornea and complete the nucleus management. For irrigation aspiration, very little cortex is left, as is the case with the most white cataracts. I try to remove the central posterior plaque, but is very adherent to the posterior capsule. I even tried the hydropolishing method to remove the plaque from the posterior capsule, but it doesn't work. I fill the capsular bag with viscoelastic for IOL implantation. A single piece hydrophobic lens is implanted. Now I want to remove the flimsy iris fibers so they do not come in the visual axis in the post-op period. Viscoelastic is removed from above and behind the lens. The remaining fibrous iris attachments are also removed. This is the picture from the first post-operative day. The cornea is clear, the lens is well centered. There is no to minimal inflammation in the anterior chamber. Thank you for your kind attention and see you on the next one.